Where's another, besides IV therapy, who can think of another endotoxin reaction? It was on that last slide. From the environment, right? Sick building, toxic mold, things like that. I'm going to skip these pretty fast because I want to have some time at the end, and we only have about an hour left for you guys to ask questions of what you have read through the slides. So feel free as I'm going through these, because I hate it when people give presentations, they just read the whole slide to you. If something catches your eye, you know, say, oh, hey, I have a question about that. Otherwise, I'm going to go through these pretty quick so we have time for more hands-on stuff. One note about epinephrine, and we're going to go over some details when I do the emergency preparedness stuff. I don't use EpiPens in my clinic. I have 11 rooms, so put one in every room would cost me about $3,000. So we have a single dose vial, a syringe, and 2 needles, drawing and injecting. And we have those in a sealed bag with a huge 3x5 card that says for IM only. You know, so that's the kind of emergency preparedness you want to have in your clinic when people are kind of a little bit panicked. You want to, you know, big reminder that that is to inject in the muscle, not to clip to the IV or something. So we put little cards in there for our providers just as a reminder. So it's about creating systems and having these kinds of forethought so that you have to think less when you're kind of in a panic and the patient's going anaphylactic and you're like, is it 1 to 1,000 or 1 to 10,000? Which one goes in the muscle? Big 3x5 card says this one right here, and everything you need is in there. You don't have to grab here, grab there. So if you do stuff that could lead to any sort of reaction, keep that in mind. In 10 years practice, I've never seen an endotoxin reaction, so I'm just going to kind of zoom through this here. A little bit of therapy advice: nausea, no dose steroids. All right, let's talk about lymphedema. Now this we see often. Not really an emergency, but you do want to be able to manage it. Pretty straightforward there. Ascites, obviously you're going to see this in liver failure, heart disease. Diuretics are key. You want to make sure that if you're doing IV therapy, you look at your osmolarity. Cerebral edema, not something I've seen. Have you seen a case of cerebral edema? Pretty rare.
You shouldn't be at your office if that's cerebral edema.
Yeah. So again, check your osmolarity if you're doing IV therapy. Fluid overload, see this all the time. So let's talk about this a little bit. This just happens when you dump something too fast. So watch with those: elderly, compromised kidney function. Watch for the signs and symptoms as listed, and watch your flow rates. Raise your hand if you're doing IV therapy. Oh, so okay. We'll go into details on these here. Okay, I'm going to go slide so you can't see it. Physical exam. You suspect fluid overload. You listen to the lungs. What might you hear? Good. All right. A cheat sheet for you. A little cheat sheet. Questions on this one? All right, let's talk about diuretics. We all know how diuretics work. I'm sure you all have this memorized. Anybody not have this memorized? Okay.
Did you guys have to draw this in school?
We had to draw this in school. No, I'm teasing. Nobody has this memorized. That's why it's on.
Oh, I'm like, well, you know, you guys are genius or something.
There we go. No, you got to look at this every time. That's why I put it on there for you. All right. Here's a little list of hypertensives. One thing to think about, hydrochlorothiazide, very commonly used for hypertension. Who uses that for hypertension? You guys use that a lot? What about chlorthalidone? You guys use that? That's actually the preferred agent. And so a lot of research in the last 10 years, people are kind of stuck on hydrochlorothiazide. A reminder on aldosterone and how that works. Any questions about that? Who uses spironolactone as a treatment for PCOS, hirsutism? So keep that in mind that this is how it works.
I know what my clinic does.
Yeah.
I don't do anything yet.
Some dosage guidance for hydrochlorothiazide. Okay, let's talk about angina. Who says angina? Who says angina?
Angina.
Say one or the other.
One or the other?
Angina first, not raise our hand.
I said, who says angina? Who says angina?
I said it.
Stop it, you're wrong. All right. So we got some. So who sees patients with angina? Anybody? Okay, so you've seen a few. What's your tips? What do you like to use?
So when you say I see them, I was a nurse for a long time, and I've only recently started my residency.
Oh, okay.
And I work in integrative urgent care, so
Very
sort of
cool.
a different dynamic. I mean, they'll come in, they'll have chest pain, they'll run an EKG. Are they on nitro? Do they need to be on nitro? Is it stable? Is it unstable? So I don't know that I have any pearls of wisdom to offer.
That's pretty much it. You know, most of the people in our practice that have angina are already on a prescription for nitro, or I refer to cardiology to have them prescribe that. It's not something I manage myself. We do keep some in office though to have in case of emergency. And that's about it for it. I mean, it's usually pretty straightforward. This is how, am I going?
Since Sage is going really fast, we're going to talk about all this in more cardiovascular focus in 3 months.
Yeah, if you're like, hey, I want to know more about that, just like I said, raise your hand. I think Mo already went through this. Some naturopathic stuff. I like arginine a lot. Who knows what to combine with arginine to make it work better? Another amino acid. Citrulline, good. Arginine, citrulline, very synergistic. Always use those in a good combo. Magnesium works okay. I like arginine, citrulline better. And then a little bit of zinc. I have a formula that combines all 4 of those together. I think I get it through Zymogen. I forget what it's called.
ITI, since they're here sponsoring, they have a Vasofill.
Vasofill.
Vasofill works really well. It has arginine and citrulline.
Does it have magnesium though?
I will find out.
Yeah, go find out. What's that?
You said ITA.
Oh, yeah.
Oh,
That's
okay.
what
ITI is all therapeutics, they're
I'm
outside.
like, is this
Almost all the professional brands have products with that combination, and it works not super fast, not as fast as nitro. So keep that in mind. This is more for daily prevention. Rosalie?
I'm just wondering, how does zinc work? What's its mechanism of action?
Zinc mechanism of action, specifically for it's a necessary cofactor in the nitric oxide pathway. To put it more generally, I don't actually know the specific step that it's in. All right, anaphylaxis. Mo kind of covered this a little bit. What's the hallmark sign? The very first one, patient says, I feel funny. Yeah, they almost always say, I feel funny. Nobody tends to really just suddenly go anaphylactic out of the blue. They get very apprehensive. So don't disregard apprehensive patients. Like, oh yeah, you're just whatever, vasovagal have. No, like really pay attention and say, well, what exactly are you feeling? Do you feel anything in your face or mouth? Is the first thing I ask. Because those are the next symptoms. And then get their vitals, like Mo said. Look for that hypotension, all the other symptoms. Definitely check for sudden death, make sure that's not present. But you generally have time if you're paying attention. If it gets to the sudden death part, you really missed the boat there for probably quite a while. So if you're doing anything that could possibly be, so what's something we do in primary practice could cause an allergic reaction? Let's skip IV, we know IVs can do it. What's something else? Vaccines, right? Right. So I've been doing vaccines in my clinic. We follow the ACIP schedule pretty regularly unless there's an indication not to. Never had an anaphylactic reaction in 10 years. Fern, you guys do probably more than us.
Mm-hmm.
How often have you guys seen it?
I've never seen it from a vaccine.
Yeah. So it's on the list. It does happen, but it's super rare. So what's something else?
We do allergy skin testing.
Yes, that's a big one. I do that too. That one's more common. Again, I haven't seen it, but I've had some people get close. I've had to just dose them with not epi, but what's the other thing? Benadryl. How much would I give them if I was doing an IM?
Well, you can start at 12.5 and go to 25.
50. Just go straight to 50 IM.
And this for adults.
Yeah. And so, anything else? One more. Naturopaths used to do it a lot. We don't do it as much anymore. Iron shots. Yeah. Just don't do iron dextrin.
No, I am.
Yeah, use Benefit. And that's it. Anybody else?
There is no magnesium in Vasofill. There's arginine and citrulline. Yeah, don't do IV shots.
Good.
Do iron IVs, but not IV
All right.
shots.
Yeah.
All right, make sure I'm going the right way here. Okay, here's a little thing. You know how to type 1 versus anaphylactic. Basically, it's just a matter of effort and magnitude of intervention. Like I said, Benadryl can be given IM or IV if they already have an IV in. Obviously, that's the quickest way to do it. Know your concentrations. I'm going to go back. Wait, no. Okay, wait. All right, now I'm going to ask. So, what's the concentration to give IM? What concentration? Epi.
Happy.
What concentration IM? What was that? 1,000. Good. So, obviously, do not do 1 to 1,000 IV. Oxygen, you know, you can try to remember all the liters per minute. We've just got a tank, put it on, turn up full blast. You can, you know, it's hard to get too much oxygen in an emergency situation. So 15 liters per minute is the max. And then, like I said, you guys seem to know your concentrations. This is just a study that says, is there a huge difference between IM and sub-Q? Most of the data supports IM, though sub-Q has also been used. But in emergency, it's just nice to kind of just stick it in there.
Where do you stick it, by the way? I mean,
That's
yeah, I'm sorry, that was a bad
I'm
question.
sorry, I don't like
That was a
that.
bad question. Lateral thigh.
Yeah, stick
Stick
them
together
with.
back here, apparently.
All right. Now, I wouldn't really say that you're managing anaphylaxis with steroids in your office. Really, you're going to give them the shot. You're going to call EMS, and they're going to be there. They're going to take it from there in the ER. But you should know, just in case, if you're in a very rural area and it's going to be a while, you don't want to have to keep sticking them with epi. You could start this process for the EMS if needed. I brought my inhaler or my nebulizer today. If anybody doesn't know how to neb, I can show you. I think you probably all should know that by now.
One thing that Sage went over, it's in the slide, if you're doing an IV, do not discontinue the IV. Stop it, maybe switch it to saline, but don't discontinue, because if EMS comes in, they're gonna need venous access, so they just use yours.
Yeah, I think that was in the first slide. Yeah, always leave that line in, switch to normal saline. Histamine blockades at home. Get your H1, your H2s. You can do some oral prescription for steroids for people who's having more semi-acute allergies. These are all pretty straightforward. Anybody have any questions about how to prescribe oral therapy?
Ranitidine's on recall right now, right?
What's that?
Ranitidine is still on recall, right?
Yeah, don't use ranitidine.
Yeah.
Is that it? Oh, that's, yeah.
Yeah.
Causes cancer.
Yeah.
In an acute situation, you could still use it. But, yeah, surprise, surprise. Can't be trusted. So that's Zantac for anyone over the counter. So your patients could be on it already. So ask them. If you have a patient who's like, oh, I've got heartburn, I'm managing it over the counter, have them switch to omeprazole, but anything but ranitidine. Quite a bit of cancer causing stuff in there, actually, which is, of course, disappointing how it slips through the system. All right, airway management. Some important stuff. Do your ABCs or your CABs. Airway, of course, must be open. Breathing, super important. Access perfect. This is basic stuff. Obviously, we're not dealing with a lot of hemorrhage and acute blood loss, so just follow your ABCs. One thing is, if a patient doesn't, you do your ABCs and you're concerned about the patient, do you immediately call EMS? Anybody? Raise your hands if you would immediately call EMS. Good. Don't do that, because you probably could get them stable with just a minimal intervention. And so do your job. Don't panic and call EMS every time there's an issue. Someone's fainted, you know, it's hard to tell if they're breathing. You know, you're a doctor. Do your job. Go through the process. If you're a kind of clinic that's calling EMS like once a month, one, it's going to look real bad for your clinic to always have an ambulance up front. And two, the EMS guys are going to get a little tired of you, and the ladies. Obviously, your goal is to stop death. And so do your job while you are managing the situation. Assess for shock, as Dr. Mo just went over. And figure out, am I doing allergy? Am I doing diphenhydramine just because I was doing a skin test? So think about what you were doing. What is more likely? If you're just doing a skin test, what is it going to be? It's going to be anaphylactic, right? That's the problem. If you were doing a magnesium IV for someone with a migraine, what's the problem going to be? Was that? Be shocked, right? So you kind of already know what kind of reaction you're dealing with. It's not like they just dropped out of the blue. So you should have stuff on hand to manage that. All right, who has an AED in their clinic? Hopefully everybody. Who does not have an AED in your clinic? All right, get one.
Who also knows how to use the AED? Not the only have it. Okay.
Yeah. So I brought mine here today. It's one of the fancy ones. You can come check it out. It talks to you, tells you where to stick the pads. I wanted to make it as foolproof as possible because I'm not know who is going to be using it. Is it going to be staff? Is it going to be a doctor? And so you don't have to have the fancy talking ones. You can just get one of the basic ones. The basic ones are about $700. The fancy ones can be as much as $4,000. So depending on the needs of your clinic and what you've got, make sure you have that. That's probably the most critical piece of life-saving equipment you have in your clinic. Talking about oxygen, everyone's got an oxygen tank in the clinic, right? Got to have that oxygen. I've only had to use my oxygen once in 10 years. Guy came in, pneumonia, said, "Can someone please see me? I'm really sick." Drove himself, and I put him on O2 sat right away. O2 sat is 72. And so he's very ashen, he's semi-conscious, and put him on 15 per minute, called EMS, they got there in 2 minutes, just as my tank was running out, because I had it on full blast. And so that's the only time I've had to need it, but I did need it. If I wouldn't have had it, he might not have made it. So keep that handy. It's super simple to use. Most people, you can just slap a rebreather mask on, that's the one with the bag, and that makes it so they're getting pure oxygen every time they breathe. You can also just use a normal respiratory mask if it's someone who's just kind of like their O2 sats are 90 and they're just feeling a little lightheaded. No, you have?
We're going to talk about all this stuff. No, I didn't have it.
All right, so there's all the different kinds of deliveries. Obviously, like I said, someone's a little dizzy, lightheaded, put them on a little nasal cannula. It's comfortable. They don't tend to freak out as much. You got resuscitation masks. That's for people who are non-breathing. You got the ball, so you can breathe for them. Non-rebreather, that's the one with the bag. Those are the three I keep in my office. A little bit about how to use each of those. Does anyone have any questions where you want to spend some time how to use those different kinds of masks? Anybody? All right, good. I'm glad you all know that. And in summary, assess quickly and fully so that you don't call EMS and then kind of look dumb when the patient's fine by the time they get there. Respond as quickly as possible. Make sure you have a plan. Think ahead of time so you don't have to think during the time. I can't emphasize that enough. It should just be a protocol, and there should be hardly any thinking involved when there is a national emergency. And of course, there's magnitudes of emergencies. There's drop everything, everybody drop everything, come help now, and then you can kind of deal. I got this. We'll let everyone else in the clinic know everything's fine. If, of course, firemen are charging through the door, you want to let them know there's no fire. Patient passed out, we're just transporting them. Communicate with other people to mitigate that anxiety. And know when to use EMS and when to not. All right, let's talk a little about airway emergencies. Croup. Who knows, if you suspect croup and you have access to x-ray, you send them to an x-ray, get an x-ray back. What does it look like? Ready? Yes, you have a thumb sign, right? So this is something you guys probably see a lot. I think probably Lauren will talk more about croup since she's doing the pediatric portion. So I'm just gonna kind of go over the basics here. Look for especially for that drooling. Kids who are croupy and they're drooling, they're in trouble. That's those blue lips. High fever can be a sign. Look for the lethargy with high fever. That's really a dead giveaway that they're not getting oxygen there. All right, let's talk a little bit about some of these agents here. I don't know about that. Let's talk about the balance between the two. All right, I think emergencies can just sometimes be a balance between sympathetic and parasympathetic activity. And it's just about balancing out those two. Usually the sympathetic's kind of going nuts and we have to calm it down. So here's all of our sort of alpha, or our adrenergic receptors. We have alpha 1 and 2, beta 1 and 2. You guys should all know that from your boards, probably have that fresh in your minds, the difference between those. So here's just a little bit of the medicines and where they work. Obviously, the most commonly used urgent medicine is epinephrine. But there's a list of others that you might consider having at your clinic. The only one of these I have at my clinic are epinephrine. I have pseudoephedrine just as a convenience for patients. Atropine, that's it. Albuterol, usually in nebulizable form. Does everyone have albuterol nebulizable at their clinics? Raise your hand if you do. Yeah, if you don't have it, definitely get a nebulizer with albuterol. That's something I use at least once or twice every winter. Got a really sick kid coming, lungs are super congested, O2 sats are down, we're going to put them on a mask and get that nebulizer going. We have one that goes directly into the mask, it's kind of nice. Okay, any questions about that? Parasympathetic, sympathetic agents. Pretty straightforward in case of most naturopathic practices. Who's ever had to give someone an epinephrine shot? 3
Drew
people.
one up. Drew one up.
Drew one up. Yeah, it's pretty rare. So, but it will happen eventually. So just be ready. And let's talk about steroids. Who prescribes Cortef for adrenal fatigue? Right. So that's kind of a common practice for chronic fatigue. So hydrocortisone is kind of the. You guys all know how it works. Let's just talk about potency. Hydrocortisone is the one, and then other agents are listed kind of how they compare to that. So look at dexamethasone, it's 30 times more potent. And so just be really careful when dosing steroids. I've only used dexamethasone, I've only prescribed it once in the last 10 years, but I did need to. I need to make sure that it was the appropriate dose. It's a super strong steroid, and it makes people have severe personality changes, mood shifts. The magnitude of side effects you get pretty much goes up with these numbers. Who does steroid injections? Anybody do an intra-articular every once in a while? Put a little splash of steroid in your soft tissue injections every once in a while. Nobody? Well,
we'll get you guys going.
It sometimes is indicated, and you have to remember that these are absorbed systemically, even though they're using it for a musculoskeletal indication. You got to keep in mind, what's probably the thing to keep most in mind if giving someone a shot? Let's say if triamcinolone, they got total knee replacement scheduled for 3 months, they're just in a lot of pain, help me out doc, give me a big dose of triamcinolone. What could happen? What kind of patient should not get a steroid injection?
So I'm just going to go hard after that.
Nope.
Maybe,
Could be more immediate.
maybe people who are prone to rupture or degradation.
No, he's going to get total knee replacement anyway. Diabetics. Be careful giving steroid shots to diabetics, right? Can make their blood sugar go all wonky. I generally just don't. I just say, oh, I'm sorry, you have diabetes, I can't give you a shot. Because their blood sugar is going to go nuts, and it's just not worth it.
You don't give them any steroid injection at all?
No.
You can still do the shot, just don't put steroids in.
Yeah, I'll give them a different kind of injection, PRP, Prolo, something different. But no, I don't give diabetics steroid shots unless it's like critically urgent for them, which it rarely is. So I'm just trying to relate these to our practice. I think a lot of docs are using prednisone on a regular basis. I hope not. All right, let's talk about any question about steroids and their use.
Can you, when you say lots of doctors are using prednisone, I hope they're not. Can you be more specific?
Yeah, dosing people on daily doses of prednisone for autoimmune conditions, right? We can do better than that usually. But of course, for emergency situations, Dr. Brooke, when would you use a Medrol dose pack?
Well, we've had to use it for someone that had an allergic reaction to a drug before.
That's a good one. Yeah.
I've had to use it for a really bad ear infection, ear, nose, and throat infection, sinus infection.
Mm-hmm.
It wasn't first line, but eventually we went there.
Yeah.
Those are usually 5-day courses, they're not
So these are short
Yeah,
courses.
so I think the difference is low dose cortisol,
Yeah.
and and even at that point, you're not using prednisone at that point.
Right.
You're using hydrocortisone. So really at this point, you're talking about massive inflammation. And I also have used a 5-day course for acute whiplash injuries. If you think it's a disc, personally I had an injury that we did do a 5-day course, and I think it's probably what stopped me from needing surgery.
Awesome. Yeah, those are all good indications. What are some of your health concerns if you prescribe a 5-day dose pack for a sinus issue?
Are you asking me?
Mm-hmm.
Fungal infection, looking for immune compromise, so I wouldn't necessarily do it if someone was sick of pneumonia at that moment, unless you were using it to bring down the inflammation of pneumonia.
Yeah. And then watch those blood sugars too.